Good afternoon, and welcome to today's event, Transforming Care Delivery, Driving Systemic Change to Fully Integrate Health and Social Care, presented by Unite Us and City and State. I'm John Lentz with City and State, and I'm happy to be your host this afternoon. Today's webinar will cover some of the biggest issues in healthcare today. During this event, experts from New York and Pennsylvania will examine challenges around community-wide care coordination and look at how meaningful data helps achieve social care coordination at scale. Before we get started, though, let me note that you can submit questions to the Q&A section at the bottom of your screen. During the panels, as time permits, we may take some audience questions. Any questions entered in the chat section, however, may get lost or go unnoticed. Please make sure to send any comments you have in the chat to all panelists and attendees so that everyone can participate. Now to our keynote speaker. He co-founded Unite Us in 2013, creating meaningful and sustainable cross-sector partnerships with leaders in government, healthcare, philanthropy, business, and community. He's leading Unite Us on its mission to launch coordinated care networks in every county of every state by 2023. Please join me in welcoming co-founder and president of Unite Us, Taylor Justice.
Thank you, John. Appreciate that. And it's wonderful to be with everyone today. It's an honor to partner with City and State and bring this crew together to talk about some needed change in our country and how partnering with organizations on the ground that do this work every single day and providing them with technology to better serve individuals and families. It's definitely an exciting time. And so for today, I wanted just to highlight a few things that we've noticed over the years. And as John mentioned in my intro, Unite Us has been doing this work for almost a decade. And 10 years ago, SDOH technology and infrastructure really focused a lot of its efforts around referrals. And those referrals were tied to resource directories. Those resource directories could be digital. Those resource directories could be a part of an Excel sheet or could be a part of a binder. Or if anyone's ever been to their primary care doc or a community-based organization, the dreaded wall full of brochures. And I think as the market has continued to advance and realize that we have to continue to move further and continue to innovate, there was no better opportunity during the pandemic to really see the need for community-wide care coordination. And so I think it's really important for us to kind of reflect on some of the lessons we've learned over the years and really the importance of wraparound care and meeting people where they are so that we can address social determinants of health and continue to impact collective health and overall well-being of individuals that we serve. And so really focusing on that address component. We can no longer just identify that someone has a need, hand them some information and hope that they figure it out within the community. I think the lessons have taught us that during the pandemic, you started to see a lot of community-based organizations either had to shut down certain programs or shut their doors completely. And in communities like North Carolina, where 46% of organizations had to shut their doors, the need for coordination and identifying not just that an organization is open, but that they have supply, they have capacity to address those needs became really, really important. And so I think the lessons can also teach us about how care coordination can be applied to other sectors of the economy, like education, like criminal justice. And we can replicate many of the same types of partnerships that healthcare have created around SDOH to improve whole person health strategies for children, for families, through the school system, or for those reintegrating into society after a period of incarceration. So in addition to the time we spent on building infrastructure that allowed historically siloed sectors like healthcare and government and the community to coordinate with each other, what we need to continue to do is drive investment directly to those community-based organizations to ensure that people access critical resources. We all know that SDOH, social determinants of health, account for nearly 80% of someone's overall health and well-being. So to improve someone's health, it doesn't just happen within that clinical setting anymore. And so we need to continue to drive resources to these organizations in the community that have historically been the backbone for this care to ensure that they have adequate resources to address needs, to address the demand, and ensure people are connecting to the services that they need. So by continuing to strengthen partnerships across health and social services, tackle difficult problems, we can do that as a united front, as a community that is leveraging data to translate community needs into action, to build the essential social care infrastructure that we need to improve health. And as John mentioned in my intro, that's really where we focused our time of being a technology tool to better equip organizations that have been doing this work for decades with resources that allows them to operate at the top of their license, to effectively connect with one another, where the century point doesn't have to just be crisis. We can be proactive with our engagement. Now, when you start to create an infrastructure that brings different sectors together, it's really important that we focus on privacy and keeping information secure. And I know today on our panel discussion, we're going to talk about privacy on the criminal justice panel specifically, but I think it's really important to identify that we can no longer just be satisfied with making a referral. And when we talk about community-wide care coordination, there's really two big components to that. There's the referral, which we define as something in transit. Org A sends information to Org B on an individual that has a need outside of what their organization can facilitate. Then when Org B accepts that referral, it turns into a case, meaning they're taking responsibility for that care all the way through to completion. When you build this infrastructure, you have to make sure that the legal structure and the partnership agreements are in place. And so we also want to ensure that clients feel protected, that they own their data and who has visibility to see it. So we ensure that a client explicitly consents to participate within the Unite Us network, that just basic information can be shared with another organization. Referrals will not be shared with other organizations unless we receive that consent. And only organizations that are providing services to that individual have the ability to see that individual's care. And in some cases, we deal with very sensitive service types. When you think of domestic abuse and other areas where we need to compartmentalize data to ensure that maybe just a set of eyes, one individual within a particular organization can see that information. So we've gone through the engineering work to create an ecosystem that allows us to be HIPAA compliant, FIPS, FERPA, you pick your security acronym. We've gone through high trust certification so that we can deploy technology, allowing the organizations to operate at the top of their license, to protect client data, and ensure that we're creating an ecosystem of trust and also efficiency. And so Unite Us does not sell client data to third parties. We are a vessel that allows these organizations to communicate with each other in an effective way. Organizations own their own data. The individual that's asking for assistance owns their own data. And so it's really important that you build that infrastructure so clients only need to tell their story once. Gone are the days where someone has to relive certain trauma or tell their story multiple times because that information isn't traveling with them with that community-wide care team. And this allows us to significantly reduce barriers and stigma associated with seeking care. We want social care to be at the same priority as healthcare, and you have to build sophisticated systems that protect information and allow us to effectively work together as a community to wrap around care to individuals in need. And so when you build that infrastructure and you create an ecosystem that prioritizes privacy and that prioritizes consent, and you have multiple different layers to that, you can then continue to innovate. And so one of the things that we've taken on as our responsibility is not just to stop at a referral, is not just to stop at an outcome, but how can you then allow us to be proactive in our engagement instead of a system that is reactive to an individual that they have to come to us and explain all of their different needs. And so we've invested a lot into both insights, which we identify as analytics that empower intelligence at an individual level, at an individual organization level, where they can ask questions of an individual to maybe get ahead of some issues that they may have, where they show up into one organization thinking maybe it's housing or maybe it's food, and they don't understand that this organization has access to a much broader network of resources that they can connect them to. And so we can now uncover needs and preferences of needs proactively and design tailored social interventions, engagement plans, care strategies for your population. And we can transform how we think about health equity and population health initiatives, because now we can start to identify that supply chain that we create. As individuals are connected to organizations, are we seeing capacity constraints? Are we seeing just flat out gaps in services where communities don't have a program, but it is a big driver of need? Or are people not accessing care as efficiently or as quickly as they should? Can we optimize that network? The data that we're able to pull and to identify some of those gaps give the entire community the ability to work off of the same sheet of music, to leverage the same piece of data, to then go advocate for additional funding or additional philanthropic opportunities, or directing government dollars to address specific targeted issues that our communities face. Because not all communities are facing the exact same issues at the exact same time. And you need to make sure that you have real-time data, that we don't have to pull from multiple different resources where you have to jam together multiple different Excel sheets to try to see that holistic picture. And so what this does is this powers every angle of a member's care through data. And it empowers organizations in the community to continue to work with each other in the most efficient and effective way. And so you have this data and analytics component where we now have real-time dashboards where we can see activity of referrals within a community. We have the ability to be proactive in our engagement and tag what we call social needs scores to identify, are we improving an individual's path? That could be through economic mobility, or that could be for housing insecurity or food insecurity. Are we addressing all of those components as a community to ensure that we're having a positive trajectory on that individual or family's overall health and well-being? And when you have this data, then you have tools to then drive action. And so then we focused on building what we call our payments functionality, where we started to see for the first time governments, philanthropic organizations, healthcare entities, both provider systems and plans, investing in communities around specific service types. But what we were seeing is they were still thinking about it from the healthcare lens and trying to incorporate it into typical revenue cycle management within the healthcare arena. Any of my healthcare friends that are on the line here today will know that isn't as efficient as it probably should be. And so when you're asking community-based organizations to then kind of follow that regiment, it creates barriers to care. And it creates issues where they have to then leverage multiple systems to then be reimbursed for the services that they're providing. So from a payments perspective, we wanted to make it very, very easy for community-based organizations to be at the same table within these funding mechanisms to then be reimbursed for the services that they provide. Now that can come through state Medicaid 1115 waivers, like we're seeing in the state of North Carolina, where they allocated $650 million of their Medicaid budget to social interventions, paying community-based organizations for this work. We know that the state of North Carolina is going through their waiver at the moment, where they can drive performance to take care of individuals within the state. And we also see Pennsylvania through their statewide resources, information and services enterprise project, where they're looking to create the infrastructure that better connect government, healthcare, and the community. But really what we have the opportunity now with this data is to drive funding to address those gaps, but also create an economic alignment between healthcare, social care, government, and the community, so those organizations are reimbursed for the services that they provide. We believe at Unite Us over the next decade, we can drive $300 billion, and that's billion with a B, back into the community, not to Unite Us, but to these community-based organizations that are doing this work on the ground and providing them the appropriate resources to continue to address this care at scale. And so until now, governments, health plans, providers, foundations have struggled to identify and partner with community-based organizations, to contract with them at scale, to coordinate care and collect data that they need to prove the value of social care. I think everybody that came to this call today understands the value of social care, of ensuring that someone has a roof over their head, food in their belly, access to an employable wage. But when you have to create systems that allow us to wrap around those individuals, but to continue to fund those initiatives. So the social care payment solution allows all stakeholders to access and pay for social care through an integrated process and a technology platform. The solution offers payers the ability to partner effectively with social care providers, manage programs for efficiency, increase program impact, and ultimately what we're looking to do is create an environment where folks don't have to be in cycles of government assistance in perpetuity. You're creating an ecosystem where you can step folks out of, be it crisis situations or they're just in a situation for a period of time, to quickly guide them out of those situations so that they can lead a life of self-sufficiency and that they can lead a life of dignity. But asking for help in that first moment is critically important. And if we don't have the systems in place to address those needs, you're going to create a frustrating environment for individuals that are seeking care. And so we're really excited with the payment solution so that we can, help folks access a contract network of community-based organizations, streamline eligibility for services and authorization processes, simplifying invoicing and billing and reimbursement and computer partners and services, and measure the effectiveness of this care. We talk a lot about, economics and technology and things of that nature, but ultimately what we're doing is we're creating a new model for service delivery in this country that has previously haven't put a highlight or a focus area on social care. We know now through multiple data sources, Robert Wood Johnson Foundation and others, that social determinants of health are a key indicator of someone's overall health and well-being and their economic mobility and a number of other different components. If we don't have the appropriate systems, the intelligent systems to put into the hands of everybody that's on this call right now, we're not going to be able to continue to drive the needed investment so that we can ensure people are taken care of. Now, I probably talked a little bit too long than I was supposed to, but we are super, super excited to be a piece of this puzzle. We are a tool that put into the hands of individuals and the leaders that are going to speak on our panel discussions today to, again, operate at the top of their license, to provide that comprehensive wraparound care and to ensure that we're helping individuals and families with whatever situation life may throw at them, but creating a system that is efficient, that is accountable, and works for them when they show up and they have the courage to ask for care. And it doesn't have them relive their trauma, but it's something that's going to take care of them because we've all banded together to identify that social determinants of health matter, this work matters, systems and economics matter, and as a collective unit, as a unified front across government, healthcare, community, and others, we are all working off of the same sheet of music. So I appreciate the time today. Thank you so much for allowing us to both introduce ourselves, give you a little bit of vision of what Unite Us sees for the sector and all of us together. And I hope you enjoy the panel discussions. You have a number of experts here that have a wealth of knowledge, and I think action items that we can take to immediately after this session go implement and put to work. So thank you again. Really appreciate the time.
Great. Thank you for your remarks, Taylor. Very informative and a good setup for our panels. We'll go directly to our first panel. If you're on the first panel, you can go ahead and pull up your videos. Our first panel today is Transforming Care Delivery to Support Reentry. This will be moderated by City and State Pennsylvania's Editor-in-Chief, Jenny DeHuff. Jenny, I'd like to pass it on to you to introduce your panel and panelists.
Hi, everyone. Thank you so much, John. As John mentioned, this panel addresses ways to transform care delivery to support reentry for returning citizens. Our panelists today are Robert Reed, Executive Deputy Attorney General for the Pennsylvania Office of Public Engagement, Gary Jenkins, Commissioner for the New York City Department of Social Services, and Samantha Edelberg, Senior Policy Manager with Unite Us. Now, for purposes of our panel, we'll be focusing on current initiatives and opportunities to better support people recently released from prison and returning to their communities. Some key topics I want to touch on are the following: state and local regulatory opportunities, the role of community-based organizations, planning for individuals with multiple and complex needs, and coordinated and timely community-based health and social services. Now, the way I was planning on doing this is I have several questions I'm going to pose to the entire panel, and they're open for any of you three to answer. Please just jump in however you like and answer any question that you deem. First question I have for you is, how do lawmakers play a role in advancing or hindering reforms to the legal system? And what are some successful examples of lawmakers pushing for change in this area? Gary, Samantha, or Robert? The floor is yours.
Sure. I'm happy to kick us off, and I know Robert has some good things to add as well, and I'm sure Gary does as also. So I think one of the things that the COVID-19 pandemic really magnified are the pre-existing health disparities for justice-involved populations. We know that COVID rates were much higher among incarcerated populations. We know that justice-involved individuals are also often disproportionately low income and have complex or chronic diseases, including behavioral health needs. And this is often exacerbated by the fact that federal law prohibits the use of Medicaid funds to be used for incarcerated individuals. So at the federal level, we really encourage lawmakers to pass legislation to change this, ideally for folks that are incarcerated, but as a start, just ensuring that individuals returning from prison have Medicaid coverage prior to reentry. It can take a long time to get back on coverage after someone's released. And if we know this population already has pre-existing needs, I think the least we can do is to make that transition smoother. Now, beyond the federal level, there's a lot of opportunity at the state as well. And something that we really encourage is policymakers to include the Medicaid coverage for reentering populations through 1115 waivers. So I know New York State is already considering this through their 1115 waiver. California is also a really great example of a state that has requested to provide targeted Medi-Cal services to justice-involved individuals 90 days pre-release from incarceration. And this is part of their much larger Cal-AIM initiative. And what's exciting is these 1115 waivers don't have to stop at Medicaid coverage. Also in California, the state is seeking to require comprehensive care coordination to meet the full scope of health and social needs for justice individuals that are returning to communities. And this can look like, comprehensive support using tools like Unitas or not, but essentially connecting folks to community-based organizations to support them as they seek housing, as they seek employment, mental health services, getting identification, and so on. And then the last thing I'll say, because I think this is really important, and I know lawmakers are thinking about this, but something we see and think a lot about is how can we continue to invest not just in short-term pilots, but also long-term infrastructure and opportunities that will give the community confidence that state resources will be there to support their adoption. And representing a technology company that works in the community, we see so much system fatigue. And we're really committed to being there for the long run and working at a grassroots level to get community buy-in and embed ourselves into existing workflows. But what we know community partners and small agencies are really looking for is signals from top leadership that the change that they're moving towards when they're adopting new tools is that they're here to stay, and that there's a strong support, not just from the grassroots level, but from lawmakers and leaders to move all in the same direction and not have to transition again and again to different products and tools and systems.
And I would just add in New York City, we have a process when one goes into prison upon release, if they were already in receipt of Medicaid, that case is suspended. So it's not like they have to start over upon reentry. So that case is reactivated upon their release. And we get reports and files from the state and from our local Rikers Island to let us know that an individual is being released, so that case can get reactivated. I think that really sets up an individual to be successful, to meet their health needs. We're really proud of that. We work closely with our lawmakers to to ensure that if there are any other opportunities that we should be exploring, that conversation is open. We really have a great relationship with our community-based organizations to ensure upon release, one has the availability of various resources to make sure that it's a successful reintegration to society. We work well with our CBOs. We have well over 200 or 300 that we partner with. We continue to strengthen that partnership to make sure that individuals upon their release are aware of the various services that the city offers. We're working with 2 of our state partners, state prisons, that one can apply for SNAP benefits 60 days before they're released. At least we could start that process, have a telephonic interview with that individual. So we want to see how we can expand that and really actually get to the 90 days. So we're working with FNS and our state oversight to determine how can we put that in motion to make sure that folks who are being released are set up to be successful and integrate back into society.
If I could just add, excuse me, briefly. Hi, I'm Rob Reed with the Pennsylvania Office of Attorney General. So I would say that I'm going to maybe broaden the question just a little bit to say it's not just lawmakers, it's the executive branch as well that is part of this process. In Pennsylvania, and I will tell you that I spent 40 years in the criminal justice world. I was a federal prosecutor for many years, over 30 years, and saw the tragedies that also often are involved with people in the criminal justice system. And I'm talking about victims, witnesses, as well as the people who are charged and convicted and go to jail. But it's really only been the last 15, 16 years that we've really focused on reentry. And when I came to the Attorney General's office in 2017, I recommended to Attorney General Josh Shapiro that we create a Pennsylvania Reentry Council. And this was an effort to bring together people from all over Pennsylvania to focus, to be a statewide entity dealing with reentry. And so the Governor Wolf, and Attorney General Shapiro announced 5 years ago, May, that we were going to have this Pennsylvania Reentry Council. So it brought together federal, state, local, community, county officials and people who were in the system, that is justice involved, people who were in the criminal justice world, service providers, all working to share information. It's essentially what the keynote, so the speaker at the outset just talking about bringing people across sectors to work together. And in our 5 years, I will just tell you, we now have 10 committees. We are really the focus or the hub of reentry efforts in Pennsylvania. And it's really been an exciting process because we've been able to push ideas that are coming not just from the higher ups, but from people who have been justice involved, who are telling us this is what needs to happen. Because how would I know? Really what's going on. And, as a justice involved person, as someone who spent years in prison, what needs to happen? Well, we are able to share that information and then provide it up to the governor's office and others to try to implement change. And we released a report in 2021. We are doing this ongoing. But one of the things recently, and this may seem like, on the scheme of things, somewhat minor, but the legislature did pass a law that reduced some of the barriers or the restrictions that prevented people from getting licenses with criminal convictions. So, that's a huge thing. And so we're doing roundtables around the state on housing, on employment. I was just on one that related to education so that people can reduce the stigma, can understand the opportunities out there. And the last thing I will say, and I'm sorry I've gone too long, is that in addition to having this Pennsylvania Reentry Council that's kind of the overarching umbrella, there's 67 counties in Pennsylvania. We have 34 county reentry coalitions. So that actually brings the work down to the grassroots and actually serves the people within the various communities.
Excellent, excellent. You mentioned grassroots, and I just want to touch on this very briefly because there are some heavier issues I want to get to, but you all mentioned grassroots levels, and there can sometimes be a disconnect that I'm known as a journalist between this area and when it comes to politicians and people on the ground level. How can lawmakers better collaborate with community organizations and activists on the ground who have been working to affect changes within the legal system? And if you could just touch on it just for a moment.
They can listen.
Yeah, I was going to say open communication and just hearing from the ground. And what Robert said is really important. When you speak with folks with real lived experience, they can tell you what they need to be successful. You know, we can read books, we can write books, we can study it, but a person with lived experience, in my opinion, is always the best person to speak to, because that's how we learn.
Yeah, I think both of you said it really well. And all I would add is, listening, I think really bringing humility. And I think something is just a really big acknowledgement of how much work has already done, how much work predates you and how much work is being done by the community. I think nothing will aggravate someone more than someone coming in thinking that they're reinventing the wheel. When there's decades of work that are coming in behind. And so I think listening, going to community partners to capture their lived experience, but then also whenever possible, bringing folks to the tables where those decisions are being made, and I think that's really the next step. I think it's very challenging, or we can say sometimes that's very challenging to do. No one's perfect at Unite Us. Whenever there are existing coalitions and reentry coalitions in existence, like in Pennsylvania, we try to join those existing groups rather than creating something new. And when those groups don't yet exist, we try to bring everyone to the table at the point of decision to really include folks in the decisions and outcomes that are most affecting themselves.
If I could just add one more sentence. What Samantha said about humility is so important. People who have been in the criminal justice system, particularly those who have gone to prison and returned, they have experienced trauma. And that's a whole other discussion, but it's totally related to this. If you're not trauma informed and you don't have an appreciation what it's like, or at least open to or empathic to people who've had the lived experience, I understand they've done something possibly terrible in terms of their acts, but as a human being, they still have a life to live. And if we want, we're going to talk about recidivism, but if we want to reduce recidivism, we have to understand and appreciate and support people's efforts to overcome their trauma and to do better.
Excellent points all around. This is a good segue to a question that someone just dropped in our chat here, and I want to take it real quickly because it's related to what we're discussing here. From Karen, Karen asks, what is the best way to get accurate information about what to advocate for with politicians and who are considering legislative change? I know we're not prepared for this one. We can come back to it.
Well, no, let's stay with it, Jenny. Just repeat the question.
Okay. So Karen is asking, what is the best way to get accurate information about what to advocate for with politicians and who are considering legislative change?
I mean, I would say is going back to the discussion we just had, is really speaking to folks with lived experience, because they can tell you what's needed. And then the politicians, right, they should listen to what's being said, what they should be advocating for on behalf of the constituents. I would also say, in New York City, we have frequent meetings with our local advocates. And they speak directly with folks with lived experience, and we bring them into those meetings and we have those discussions. And sometimes they're hard discussions, right? They're hard issues, but we have to be there as a government to hear them in order to move forward. So I appreciate those discussions. I appreciate those meetings because it really give me food for thought and what I should be advocating for on a local level, and then having those discussions when I'm meeting with our various legislators.
And I would add that you know, it's a process like a lot of things. You first of all, I mean, the legislators hopefully have to be open to even having the conversation. If they're not even recognizing that people who are just as involved are actually human and actually, you know, have feelings and emotions and oftentimes just want to do great in their life, or at least not suffer in the same way that they have, and to simply contribute to their family and their community, that's the beginning, and that requires some education. This isn't just like you know, getting new widgets on a car. This is talking about human beings, their life, their past, their present, their future, and then bringing people within the legislative, their staffs and the legislators themselves, to actually meet with people who are just as involved. I think going into prisons to participate and actually hear on more than one time, just not to say checking off a box, oh, I did this, but to really begin to appreciate that many of our victims become our perpetrators or the people who go to jail. There is a symmetry, or there's this symbiotic relationship between all of it, and we have to understand that there are victims and people who end up going to jail oftentimes are switching places all the time. And that also, we're also putting a lot of people in jail who suffer from addiction and mental illness, and they need to understand that there's a reason why a lot of people become addicted beyond Purdue and, you know, having lots of pills. It's because of underlying issues in their life that cause people to self-medicate. So these are complicated issues, but there needs to be an education process for the legislators.
Yeah, and sorry, I know we're trying to move on. I just want to quickly add, because I'm actually really heartened by the responses we've gotten. I think it's so common in these conversations for folks to immediately point towards data, and this focus on lived experience and qualitative feedback, and really going to jails, going to prisons, hearing from folks is critical. I would just add, I do think there is a really important role for data here. You know, there's folks that are going to hear the lived experiences, and there's folks that are going to hear better the data. And I think setting up systems that are able to capture where those gaps in services are, where those needs are not being addressed, and then also where they are being addressed, or perhaps where there's overlaps in service provision, I think is really, really critical. And that's something that we think a lot about at Unite Us, is how do we start to standardize that, the metrics of understanding who's getting appropriate need, you know, where are those referral pathways going? And then when we see gaps, or we see a single population that's overrepresented, being able to dig in and understand why, so that we can elevate that, bring those to the community of practice, bring that to legislators and say, hey, have you noticed, are you aware that, you know, a huge portion of service providers are rejecting referrals because they, you know, the eligibility requirements are too stringent, and that might be a policy issue, or maybe it has something to do with capacity and more resources need to be pushed into these service providers. But I think being able to have strong data and evidence to capture what's going on the ground level and pair it with that lived experience is really important.
Yeah, I mean, Robert, Samantha, look, you both mentioned trauma, which is a really important touch point here. What are some of the most pressing needs that you most often have seen among people returning to society from prison? And question for you too, Gary.
If I can start off, I would say, you know,
Yeah.
being trauma informed is extremely critical. You know, we are humans. We come with we come with challenges, right? And if you don't address the challenges from when you was a young child, you grow up into an adult. And that's what I tell my team. We should focus on adults, absolutely, because they experience trauma in their lives, but also look at those children that's with them, because the children experience trauma as well. And if it's not treated, if it's not addressed, it's just going to exacerbate your experience as you become an adult. So really understanding and being there and having someone to talk to, that's simple, right? Just having someone to talk to about what you went through, but having an expert that can really drill down and help that individual is really going to have an impact on communities at whole. And I always I love the fact, Samantha, you said, yes, we have to marry the lived experience with the data, because that lived experience is going to inform the data. It's going to match up perfectly. It's not going to be for me, at least in New York City, it's no different. When we hit COVID and you looked at those neighborhoods, those areas that was impacted disproportionately, it was no surprise. The data led right to those with lived experience that was untreated. So being trauma informed and treating that is extremely important.
If I could add, and believe me, this is a subject that I could talk about for about 2 years, but I don't think you have enough time. One of the things we're also doing in Pennsylvania, and especially for New Yorkers who may have no knowledge of this, I was born in New York, by the way. But anyway, we have started an effort to create a trauma-informed Pennsylvania. And I'm on the executive leadership team of that effort. It's called Heal PA. There's a website. It's under Resilient PA, but Heal PA will get you there. And this is an effort to, as I say, create a trauma-informed Pennsylvania. I oversee an action team called the Criminal Justice Action Team. Within that, there is a reentry component. This is separate from the Pennsylvania Reentry Council, but the bottom line is, in both places, we're focused on providing, you have to begin with education. People need to understand what trauma is. They need to understand really how pervasive it is. They need to understand what adverse childhood experiences are and how pervasive that is in our society. And then we have to also focus on what is the impact that that's having on all of the service providers, the caregivers. I do presentations to police officers. We're trying to create trauma-informed criminal justice, training all police officers and all law enforcement in Pennsylvania, corrections. But the bottom line is we're doing it with people who've returned from prison and are in prison. There are efforts through the Pennsylvania Department of Corrections to become trauma-informed agency. So the bottom line is this is a huge culture change. And it begins with recognizing that so many people in our society have been exposed to trauma, and many people have also have suffered from PTSD. And there's so many consequences that go along with that are both emotional and physical, and they can stay with you for your lifetime. And there's historical trauma. And the whole racial discrimination, all of the issues we're dealing with race in this country, a lot of that has its history in trauma and historical trauma. So all of that is part of this massive education process that I think needs to happen. And then we need to figure out ways to, and maybe it's Unite Us is the way to do this, but we're trying to do this in Pennsylvania, which is how do we create systems that work together that provide trauma-informed services.
And I would add, I'm sorry, Samantha, I know you're going to jump in, but just, the discharge plan is important, right? As one being released from jail or prison, that should be part of that discussion, the evaluation, the assessment, and then the connection to the appropriate mental health provider or health provider. And that information, and I know I'm not a lawyer, never wanted to be a lawyer, but I know there are a lot of, security and confidentiality rules, but how do we get that information to the community, to that provider that can assist that person, and they're not starting at ground zero and starting all over again to understand that particular individual?
Yeah, I also could talk about this for ages. So I think there's a few things I want to touch on, and I think we'll get into more of it in the following questions. But a few things that I've heard, and I just want to underscore, is the really identifying and proactively identifying whenever we can what those underlying health needs and social needs are. And so, Gary mentioned there was no surprises when COVID-19 hit, and we saw which boroughs and which neighborhoods were hardest hit. And I think a lot of that is how do we start, one, screening and those discharge planning conversations, but two, embedding tools and really connecting people to care where they feel most comfortable. And that might be Sometimes that will be with a provider, but sometimes it'll be with non-traditional in non-traditional settings. You know, at Unite Us, we've worked with salons and barbershops to get folks on board. I'm still shopping around the idea, and I'm really excited about essentially putting QR codes on the back of business cards so that folks, you know, when they're in need of services, and it might not be in front of their parole officer, it might be when they're sitting at home, they can scan that QR code and essentially request services and request support. So I think making people feel really comfortable and trusted in asking for support. And then again, I think what we've said is making sure we're not asking folks to share their story again and again and again, and having to have the burden put on them to navigate an incredibly challenging social care system. You know, what can we do as providers in the technology space and the government space to really make that transition between different providers as seamless as possible, so that folks are just quickly getting to the care that they need, without having to retell their story and without having additional trauma from being rejected from places and so on and so forth.
You mentioned rejection, and look, the challenges don't stop there. And once people work on restarting their lives, you know, they need to support themselves, right? So a big challenge for released prisoners, returning citizens, is reentry to the labor market, right? And finding a job. So allow me to play devil's advocate here. And why should employers invest in hiring people with criminal records? What's the incentive?
Well, I would say very simply is one of the incentives is that there's a lot of people who are returning from prison who really want to work. And they get it. And I mean, I've traveled around the country on this one. So I will tell you, like in Mobile, Alabama, they have a massive shipyard, and they make no distinction between people who have no criminal record and people who are coming out of prison. They want the best possible worker for their workforce. And so if it's someone who's committed murder, but he's been paroled and he's out and he wants to do the job, he will get the job. I mean, I think that's the attitude. I'm not saying you shouldn't be, you know, take normal and appropriate, you know, care for through your selection process. But the bottom line is we have this massive amount of untapped employment and you know, right now we're talking about, gee, we can't get people to do this, that, and the other thing, and yet we've got this untapped wealth of employment. And yes, there's some people who need to know how to act, and there needs to be some remedial work. That goes without saying. And we need to recognize that some people have experienced trauma. But the bottom line is we have this untapped wealth of human staffing that can assist companies all over America.
And I would say, you know, honestly, it's our moral obligation, right? If someone wants to help themselves, then they did the time, they released, give them an opportunity. Let them take care of themselves. Let them be self-sustainable. I think, you know, a lot of folks go in with skills already. Why not tap into those skills that they already possess or that they obtained while they were in prison? Because a lot of folks garner those skills, get the education that they need. So why have that stigma on them now because they was released or formerly in prison? There's a lot of us, and I'm going to say this, you know, that have criminal records. No one's an angel. People do wrong and they learn from it, hopefully. So we have a workforce that need the skill sets. Let's give it to them.
Yeah, I couldn't agree more. Oh, sorry. I was just going to say, I couldn't agree more. It's challenging for me to answer what are the incentives? Because I think at the most basic level, if we believe that reentry is meant to be a fresh start, and if we truly believe that, then the question is on us is what are we doing to remove all those barriers to make sure it truly is a fresh start? And I think that falls on community, it falls on government, it falls on, you know, technology vendors in the private sector, and also in employers to invest in that and make that a true possibility for folks. And I appreciate, Gary, what you said about the education folks get in prison or in incarceration, because, you know, I volunteered for years, you know, teaching in prisons. And I think this is something that we forget about, and we don't always call out just how much opportunity there really can be for folks to move themselves forward. to move forward their education when they're incarcerated. And I think if we're investing in that, then we have to give folks a chance when they come out.
And if I could say one more word. So, I'm going to bring up the word recidivism. If we're serious about reducing our prison population and we're serious about helping people who have been justice involved, and we're serious about, simply reducing that recidivism rate, then people need jobs. I mean, how are people going to survive unless they have jobs? So it is a human issue, but it's also, if you don't want to look at it as a human issue, the bottom line is it's a law enforcement issue. We want to reduce crime. We want to, I was able to get the Department of Justice to fund a film in 2013 called Pull of Gravity. And it's the story, it's a documentary about three men and the pull of gravity back to essentially the roots of where people were. So unless they're helped, unless we help people, opening up opportunities that are really open to everybody else, and we overcome our own stigma and their stigma so that people can actually work at a job, get a decent home, actually feel that there's a future, people are going to return to where they came, and they're going to return to the streets, and we're going to have more crime. So, and I invite people to see that movie, but the bottom line, I don't get any kickback, but anyway, the bottom line is, this is about public safety, it's about humanity, it's about public health, and I think that we should care.
Totally agree. And if, folks are upon release, they want to get into the workforce. If they don't get into the workforce, then government's going to take care of them and we are going to pay.
Someone may have mentioned that movie, Rob, in the chat.
Oh, really?
Yeah, maybe not. They couldn't remember the name of it, but yeah, I mean, you raise a really good point. They teach a lot of technical skills in prison. They teach, all kinds of, you can learn landscaping, things like that. So to help with developing these skills on the outside, so to speak. So yeah, there's a lot of incentive there, I'd say. But you touched on the next subject I was going to bring up, and the final one, but it's recidivism. What are some good methods for reducing recidivism in New York and Pennsylvania that you found to be effective?
In New York, I would say it's really setting the individual up upon release, right? So I mentioned earlier that, we have a pilot in place with two jails where one can apply for SNAP benefits before their release. So when they are released, they have some resources, financial resources in place to get them off on the right footing. We are looking to explore for cash assistance as well. How do we get an individual cash assistance, SNAP, and Medicaid, so upon their release, they're off on the right footing and then have those wraparound services as far as employment opportunities. So if they get on cash assistance and they're employable, we work with our various CBOs to have them join and develop workforce strategies and work with workforce developers to connect them to employment. That's really important for us in New York City. It's proven to be successful, at least starts them off on the right ground. But if they're not ready for employment, education and training is also very important. So how do we connect them to those services? So that way, if they say, I want to be a nurse, what's needed to be a nurse? What educational, what licenses you need in order to be a nurse? We work with those individuals to get them into those programs so they can get on the road to self-sufficiency.
Well, the issue of recidivism is obviously, everyone talks about it. There's no even unified definition of what recidivism is. Let me point that out. We have found that in Pennsylvania. But the bottom line is, if it's generally people not going and committing crimes after they've been released, then one way is to help give people hope. I mean, the bottom line is that if you've committed crimes, you've gone through the criminal justice system, you've been in prison, and then you're now released, and with the myriad of challenges and obstacles and doors being shut in your face, that's not going to help you. And as a matter of fact, what I have to come back to, we have to create a trauma-informed reentry process through probation and parole, beginning in corrections, but our entire system needs to be trauma-informed. We need to begin by recognizing that people are human, that lots of people make mistakes, and believe me, I was a prosecutor, so I argued that these weren't just mistakes, these were crimes, and they really hurt people, and they did. But that's not to say that people can't move on. But if people feel that all the doors are shut, that there's no hope for them or their families moving forward, they're going to return to where they came. So the bottom line is that, and this goes back to the original speaker, the idea of us coming together across systems, criminal justice, education, human services, health, all of us working together, in partnership to say, how can we best support people who are returning? How can we assist getting them housing? What are the efforts that we can make? How can we get them health care? How can we get them the training and education they need to, let's say, be able to drive a truck across the country? The bottom line is, if we don't do this, we're going to continue to see the exorbitant rates of recidivism, which has been a complete failure. It's been a complete failure when more than 50%, sometimes they say 67% of people recidivate. Well, that's outrageous. What a pathetic system we have. So the better system is to treat people like they're people and to try to help them so that they can hopefully make better choices, better decisions, and have more opportunity.
Yeah, I mean, you really said it for me, I think, but to add a little bit, I think Robert, you were saying this in the last question, and I just want to underline it. I think we have to acknowledge that incarceration does not solve for the root causes that lead to someone being incarcerated or touching the justice system. So, fundamentally, we have to be looking upstream. We have to be looking at those root causes. And so that's really before someone is even incarcerated. What are we doing? How are we ensuring that folks stay out and we divert folks from moving into the system? But when we do think about someone returning, you mentioned what Taylor, our keynote speaker, said, and I couldn't believe it more. We certainly have a working theory of change at Unite Us, which is that if we bring everyone together and we try to bridge across these fragmented systems and silos and many different systems that folks are trying to communicate in, if we start to really close the loop and say, not just here's a referral, this is where we can help connect you, but be able to track and say, did someone actually get the services they need? And if not, how do we follow up? And how do we make sure that someone is really closing, getting the services they need, not just at that first point of entry, but if they need another service, or if there's another need that comes up, how do we continue to support someone along their long journey? Because it doesn't stop immediately after someone leaves prison and jail. And I think we have to take a really long-term view on this and a really holistic view. And so folks have mentioned, employment and housing, which I think come up a lot, but also food, education, wellness. Let's think really thoughtfully about what wellness looks like. And let's also be really intersectional about how we think about this. There's not going to be a one-size-fits-all solution for folks. So making sure we're targeted and really thoughtful and targeted in our approach, and working again with community folks and folks returning to understand what are their specific needs and how do we connect them to that. So I think it's a lot of it what has already been said, but really wanted to bring in those last points around intersectionality and the role that technology potentially has to just make this a little more streamlined.
Awesome. Well, look, thank you so much, Samantha, Robert, and Gary, for your time today and your thoughtful insights. This has been a very edifying discussion. Now I'd like to throw it back to our host, John, who will introduce our next panel.
Great. Thank you, Jenny. Thank you to our panel. We'll bring up the second panel. If you're on that panel, go ahead and pull up your videos now. Our next panel is on Medicaid transformation, trends, opportunities, and collaboration. This will be moderated by Chair of City and State's Advisory Board in New York and Chief Communications Officer at NYU McSilver Institute. Please welcome Cheryl Huggins-Selman.
Thank you, John. Good afternoon, everyone. I'm especially excited about this afternoon's panel because in addition to being the advisory board chair, as John said, I am also the Chief Communications Officer at the NYU McSilver Institute for Poverty Policy and Research. And among other things, we manage the OMH-funded Managed Care Technical Assistance Center of New York, which provides technical assistance to mental health, substance abuse, child welfare agencies, that are transitioning to managed care and value-based payment systems. So my colleagues at McSilver are watching this session with great interest, including McTAC's lead, Boris Helgerson. So, and I know we've got a great conversation in store. So, so look, as New York, Pennsylvania, and other states grapple with recent rises in Medicaid enrollment, it's a great time to check in on how the process of lowering costs and delivering better care is going. In New York State, Comptroller Thomas DiNapoli reported in December that Medicaid is the second largest category of state spending at an estimated $2.78 billion. And I'm sure many of you who are on this call are familiar with that. And a lot of this is a result of the economic instability caused by the pandemic. And because of that, monthly Medicaid enrollment swelled to more than 7 million people by February 2021. Now that is expected to decline by 1 million individuals in the current fiscal year and even return to pre-pandemic levels by spring 2024. Yet Medicaid spending is still expected to rise over the long term as people resume using non-COVID medical care, for instance. So what are the trends, opportunities, and challenges associated with Medicaid transformation, including value-based payments and the transition to managed care and behavioral health, among other things? And also, this is something that Taylor especially was talking about, but how do we ensure that these systems better accommodate care coordination and services by smaller based community organizations, including those that are focused on social determinants of health? So this afternoon's panelists are going to share their insights on this. They are, and I guess I will introduce and then ask them to wave because I'm going to introduce them all first and then we'll start. Jason Helgerson, who is CEO of Helgerson Solutions Group. He previously served as New York State's Medicaid director and as executive director for the New York Medicaid redesign team. We also have Eric Bean, who is vice president of regulatory and government affairs at Unite Us, which provides technology platforms for coordinated care networks. He previously served as chief operating officer for the state of Rhode Island and also as deputy chief of staff for the governor of Maryland. And we have Kelly Hoover Thompson. She's the government healthcare lead at LexisNexis Risk Solutions. And she has served as deputy secretary at the Pennsylvania State Department of Health. John mentioned some housekeeping before, but if you have any questions for this amazing panel, please drop them into the Q&A box. And we'll get to as many as we can. So I want to jump in and really ask each panelist, please tell us what you're focused on and how it relates to Medicaid transformation. And I'm going to ask that question of Jason first. Jason, I think you're on mute.
Yep, sorry about that. So it's a pleasure to be here today. As a former Medicaid director in New York, and then before that, I was the Medicaid director in Wisconsin. So 11 and a half years between the two, worked on many a Medicaid issue in my time. But my focus today, and really is a passion that I developed, particularly during my time as the Medicaid director in New York, is the move to value-based payments and the opportunities that are created by aligning the interests between payers, providers, and even into the social care sector to launch or unleash the opportunity for new care models, new approaches to meeting the needs of individuals that ultimately will bring about better outcomes and lower costs. And I think that win-win opportunity exists out there, and excited to spend my professional life these days working with a variety of organizations who share that interest and helping them make that a reality.
Thank you. Thank you. So I am going to ask Kelly that question next.
Great, thanks, Cheryl. Hi, everyone. Great to be with you today. Also agree with much of what Jason has shared. I've spent probably more than the last decade in interoperability and information exchange and data quality and what that looks like, not only for the healthcare space specifically, but many of the things that Taylor talked with you about early on in today's call. So in my role now at LexisNexis Government Health, we are focused on looking at all of those pieces around interoperability and data exchange and making sure that as we're looking at care across the continuum and whole person care, that we're starting with good whole person data to be able to make good informed decisions for the folks that we serve and making sure that we have the full picture across the spectrum. So you heard Jason talk about some of the quadruple aim, right? Some of those things we've been talking about in healthcare for so many years, those things are all still very relevant. The pandemic, I think, put us in a unique opportunity to frankly take advantage of improving ourselves and the system for the folks that we serve. So that, Cheryl, is much of what I'm focused on in this new role as Government Health Lead with LexisNexis. Thanks.
Thank you. Thank you. And I'm going to ask Eric.
Yes, well, Cheryl, as you mentioned, I did spend a good portion of my career working in state government, in governor's offices in a few different states. And you rightly point out that Medicaid is a big cost driver. It's one of the biggest expenses in state government. It's usually in the top two, sometimes number one. But in addition to being a cost and an expense, it's also an investment. And I think it's important that we frame our thinking around the benefits that investing in a healthy population has on all the other types of high-level goals that government leaders have. They want people to be well-educated. They want people to be employed. They want the economy to thrive. And if you are not investing in a healthy population and addressing unmet social needs, you're going to undermine all of those other objectives. Specifically with respect to Medicaid, the last role I had before I pivoted to work in the private sector at Unite Us was as Secretary of Health and Human Services. And at the time, we were setting down the path of some Medicaid reforms, modeled in part off of some of the work that Jason did when he was in New York. So I'm going to be interested in hearing his thoughts on the latest policy changes in New York. But one of those is around the opportunity to connect health and social care, address social determinants, and ultimately shift investments upstream. We know that we don't have particularly good results for the amount of money that we invest in our healthcare system. And a potential solution is to be screening for social determinants, funding interventions related to social service needs, and tracking those outcomes over time so that we can do more of the things that work and less of the things that don't.
Thank you. So Jason, this next question is for you. I'm interested in knowing what trends you are seeing as New York seeks to lower Medicaid costs through managed care. You mentioned value-based payments, but I also would like it if you can talk about what kind of models in thinking even beyond New York State, those of us on the call should be looking at. Oh, did we lose? I think we might have lost Jason for a moment.
I'm happy to jump in with an example if you like.
Yeah, sure.
So one state that I think is worth taking a close look at is North Carolina. That's a state that a number of years ago, under the leadership of Secretary Mandy Cohen, decided that they wanted to invest in health, not healthcare. And the key difference there was that they wanted to focus on whole person health and diagnose social needs and address them at scale across the state. So they were the first to do this at a statewide scale, and a number of states have started to follow suit. I think there are a few common elements that we're starting to see as states are moving more in this direction. One, we're seeing investments in shared infrastructure and technology so that everyone can collaborate in one ecosystem across healthcare, social care, community-based organizations, and government agencies. We're also seeing an increasing focus on the need to invest in community capacity. We cannot assume that if we're seeking to leverage the assets and strengths of community-based organizations, that they can take on all of that responsibility without the resources that are needed to support that growth. Have they been undervalued? Yes, but they need more stable funding streams in order to play the biggest role that they can in supporting overall health objectives. The third piece would be funding for interventions to address health-related social needs. North Carolina, through its waiver, freed up $650 million. $100 million went to community capacity building, and then $550 million is going towards a discrete set of social service interventions to address health-related social needs in common categories like housing, food and nutrition, transportation, and services for people suffering from interpersonal violence. What I've been seeing in the last couple of years, especially as the pandemic has focused more attention on health equity, is an increasing focus on flexible funding for community investment and to support health equity strategies. And that's a very welcome change that I think over time will support this rebalancing of investments between the health and social care sector.
Thank you. So as we talk about whole person care, Kelly, I would ask you, what are some of the opportunities and challenges for interoperability?
Thanks, Cheryl. Good question. And I'll just start by supporting so much of what Eric said. There's so much to unpack in this issue. And then looking at how we can be supportive through these interoperability efforts that frankly, the federal government has invested in now for many years, and our provider networks and others have worked so diligently to try to meet those requirements and to advance and be wiser with the information that we've been entrusted with. For those of you who may be following what is going on with interoperability at the federal level, you know that there is an effort, policy changes in place to create a nationwide health information exchange. That interoperability comes from 21st Century Cures, and I know many of the states have taken different approaches in terms of what their interoperability looks like. The reason this is so important is because we can't fully support folks like we talked about in the last panel. We talked a significant amount about people coming out, going through reentry, going through that process of transitioning healthcare and services into their communities. The reason that is so important is because if we don't have the services in place and the resources in place, Cheryl, to support folks through that process, we just will not be as effective as we possibly could be. We're not going to move the needle from a financial perspective. We won't increase and advance those whole person health outcomes that we're hoping to move the needle on. It's just simply unrealistic. So again, if you look at what's going on at the federal level in terms of the interoperability efforts, I'm seeing many of the states look at those pieces as well. Many of you state leaders who are on today are likely having conversations around broadband. I know some, in particular, Pennsylvania has set up a new authority and had legislation passed to create support around that broadband effort. So there are a number of things, far too many even for me to get into today, Cheryl, but practical use cases to support reentry into communities, support children, frankly, from the Medicaid population who may be transitioning in foster care families back to their birth families. There may be support from the pandemic that's needed as the public health emergency ends. There may be folks, again, from that school nurse perspective, where we need to communicate and share information to provide those children the support. So just a lot to really consider and think about in terms of interoperability, but all with that goal to have good data in place so we can support folks where they need and where they are in that place.
Thank you. Thank you. And Jason, we were just talking about care models, actually, and Eric brought up whole person care. I was interested in your perspectives on how things are going in New York State, what are the opportunities and challenges that you are seeing, but also what is going on in other states that are noteworthy that we should be looking at. And Eric had mentioned North Carolina.
Yeah, sure. In terms of just care models, and I think this is key, is we spend a lot of time talking about how we pay for healthcare, but I don't think enough energy is spent on thinking about how to deliver it to individuals and families in fundamentally different and better ways. And I think that to me is really where we need a lot of new ideas and energy and innovation, is because ultimately, you know, we can change how we pay for things, but if ultimately those payments are going into the same exact systems of care or methods of providing care, then we're going to ultimately get the same results, which is not what I think collectively anybody on this webinar today would want. There's clearly opportunities for better outcomes particularly for vulnerable populations on Medicaid. So I always love to celebrate people who are pushing the envelope and trying innovative new things. I can just give maybe a couple of examples of areas where I think that we're starting to see some innovation. First and foremost, I'm a big believer that maternity care is an area where, particularly for the Medicaid population, we need to get better outcomes. If you look at, for instance, the statistics, how the U.S. ranks relative to other countries in where we have some of the biggest disparities based on race, it's in maternity care. We have a long way to go. We're beginning to see new innovative models, whether that's using doulas, for instance, and Medicaid making that now a covered service in many states across the country, or innovative new partnerships that see beyond just the traditional maternity care bundle, meaning like, you know, when a pregnancy is determined to maybe a couple months after delivery, or maybe even the first full year of the child's life, but embracing the concept of interconception care and the idea that we need to care for these families and in fact do things whenever possible to try to extend the gap from one pregnancy to the next, especially if the first pregnancy had a bad birth outcome. So I think there's a lot of interesting, innovative things being tried in a variety of different states around, but I think it's my view at the end of the day is there's not enough, and we need to really empower. And I'm actually hopeful that the Biden administration will use 1115 waivers in Medicaid to really encourage states to try new care models, new approaches, give them the flexibility that is required to test some of the innovative new ideas.
And how would you assess so far what the Biden administration is doing with regard to making those waivers available?
Right now, I'd say it's a work in progress. As someone who's very friendly to the administration, I mean, it took them, I think, a bit of time to staff up and get themselves organized. Sometimes I think we forget that the Biden administration's only been in office for a little over a year, but we did, and I'll say it's not Medicaid related, but I think it's it gives a suggestion of where they're going, is the new Medicare ACO REACH program, which is very interesting. It replaces a Trump administration program called direct contracting. But inside of that program, I think there's some pretty significant new ideas and new approaches. Particularly, it's really an example of how they're prioritizing equity, health equity, and really trying to make providers accountable for first documenting inequities that exist, and secondly, actually doing something about it. Also, they're actually allocating more funds to organizations that serve disadvantaged, vulnerable populations. So I think that's another very positive sign. But while it's not Medicaid specific, I think it's clearly a policy signal from the administration of where they're going. And what I'm excited about is that as this administration continues on, that we'll start seeing some of these ideas matriculate into Medicaid, into not only 1115 waivers, but just into their general policy guidance and direction.
Thank you. And I would ask if Eric and Kelly have anything to add to that. Or I'm going to ask, Eric, I'm going to ask you this question. with regard to value-based payment arrangements, how can we lower the barriers to entry for the smaller community-based organizations, especially those focused on social determinants of health? And what about those who don't follow traditional healthcare rules and requirements to provide services? I'm thinking, for instance, food pantries or domestic violence shelters. How can we lower those barriers to entry?
That's a great question. And it's something that Unite Us has been confronting as we're working in states to support payments to community-based organizations for services that haven't traditionally been paid for under Medicaid and other health plans. So one of the things I would say, and this is to echo a comment I made earlier, we do need consistent funding streams to support community-based organizations. If they're addressing needs related to healthcare and they're entering into partnerships and regularly receiving referrals from health organizations, we need to make sure that they have the stable funding that's needed to scale up and meet that demand and to be able to deliver services in a quality way. Another thing that I think is really important is that we not over-medicalize community-based organizations. And you confront these issues really quickly if you start to cover social service interventions at scale. North Carolina confronted this with its Healthy Opportunities pilot. I think California is learning some lessons around this with in lieu of services. Are you going to apply all of the same credentialing requirements and rules that you would as if it were any other medical provider? Or are you going to recognize that there may be some unique things about these community organizations, the people they employ, the value that they provide, and adjust those so that it's appropriate for those specific circumstances? I think it's important to be very thoughtful and not shoehorn their work into the existing healthcare model. Another thing I would say is it's really important to focus on operations and workflows. There's not a lot of back office support. CBOs tend to be overburdened to get more work than they can handle with their funding levels. So we need to prioritize simplicity, efficiency. We need to take steps to try to eliminate or minimize the need for documentation in multiple systems. And above all, what we really need to do is listen to them and hear how they can contribute and make sure that those views are reflected in any guidance that goes along with a new regime for paying for social care.
Thank you. Thank you. So relating to that then, and I'm thinking, obviously right now I'm in New York State. And so with regard to behavioral health, which is transitioning to this value-based payment system, how do we embed outcomes into it and not just rely on HEDIS measures to determine quality of care? Because it sounds to me right now that relates to a point that you had made, that right now the measures are kind of not appropriate to the organizations. I mean, those are very process-based measures. And I also see Jason nodding. So I don't know if you want to take that first, Jason, and then I would maybe Eric can take it.
Yeah, sure. I'm very familiar with the transition that's occurring in terms of value-based payments and the value-based payment roadmap that New York has in place that governs and what basically defines what is value-based payment. And I think what's significant in New York is now 86% of all provider payments that flow through Medicaid managed care plans are value-based. And that it took about 5 years to get to that level. But so while there's a lot of value-based contracting going out there, with the point you're making about in the behavioral health space, the fact that the traditional HEDIS measure set doesn't include the kind of outcomes that I think that we are really interested in, particularly for the high needs behavioral health population. And this is one where I think a couple of things. One, I do think states need to begin to try, and I sometimes say this about measures, is that if you talk to the data scientists who are experts in HEDIS and other outcomes measurement when it comes to healthcare, is that you need measures that have been validated, and you want to use validated measures typically when you're going to be making reimbursement based on it. And so that sort of becomes this challenge of of you can't validate a measure until it's tried and tested. And I think what we need across the country is efforts to try new, different measures, particularly for the high needs behavioral health population. And I think that this gets back to sort of make a broader point is most Medicaid states turn over the responsibility of managing the day-to-day operations of the program to Medicaid managed care plans, and New York, Pennsylvania included. And so I think that we need to look at the contracts and how we structure those contracts and what we require plans to do very seriously, and really see how we can use that contract to drive innovation, new practices, new approaches. I just last thing I'll say about, just to give you an example, actually relates back to the question Eric answered just a few minutes ago around what we can do to incentivize more integration between social care and healthcare. And one of the things we did in New York with the Medicaid managed care contract was we required that in the more advanced value-based arrangements that either the provider or the payer, the insurer, had to contract with a CBO, community-based organization, to help address a specific social determinant of health need of the population that would be impacted by that value-based arrangement. And so I think that, and I think you can go even further than what we did in New York, and actually require health plans to spend 1% of the premium they get from the state, expend a portion, at least a portion of that. Let's start at 2-3% of total premium on efforts to address social determinants of health that includes direct contracting with CBOs. I mean, I think those are the kinds of things that could be done by states today. Certainly, the federal government could encourage it. But I think if we really want to come up with new approaches that address STOH, particularly for the high needs behavioral health population, I think states have to use their purchasing power and their authority through those contracts to drive innovation.
Thank you. Eric, was there anything you wanted to add to that?
I think Jason gave a great overview. I would just cite back to something Jason said earlier, that in addition to thinking about, payment is one way to drive change in the healthcare market, you do have to think about delivery system and what it takes to operationalize changes. And I think there's still unfinished business in most places around the country and more effectively integrating behavioral health into primary care pathways, those behavioral health, physical health connections. And I think this is not an issue unique to the behavioral health space, but there are provider shortage challenges in many places, and we need to address that if we are going to address the pent-up need for behavioral health services across the country.
Thank you. And Kelly, do you have anything to add about the data sharing challenges?
Yeah, there's a few things actually that have struck me as Eric and Jason were talking. Prior to this, I spent years setting up a national collaborative around data exchange and working with health information exchanges and working with communities and partnering between Medicaid and these community-based organizations you've heard about today. There are a number of challenges that still exist, frankly, that we've been talking about for many years. If you look at some of the social service organizations you may be partnering with, consider how many of them may have an electronic health record at this point, or an electronic system, or even folks, on staff who are well-versed in and able to provide resources through that electronic means. If you look again at what's going on in terms of policies at the federal level, you'll hear a lot around consumer mediated or consumer directed exchange. And so giving people the ability to access and share information and access services, especially, Cheryl, as we've talked a lot through the pandemic with telemedicine and remote access, think about even some of the refugee resettlements, and having tablets or devices available to even support folks where they are in that journey. So there are a lot of challenges, I will say, that still remain, but I'm also optimistic and very excited about the fact that there are some great opportunities for us too. And again, as we look at that public health emergency, next steps in ending, how do we make sure that we have good data for people? How do we look at supporting not just that individual as state leaders, how do you look at supporting that whole family? And what do we do with the data that we have to do that?
Thank you. So I have a question from the audience, and I also want to encourage folks to continue to enter their questions into the chat box. This is from Yvonne Ward. CMS has issued guidance that home and community supports can assist those experiencing homelessness, particularly the shelter population. However, Medicaid managed long-term plans in New York refused to assess anyone in a shelter. Is there any solution to address the needs of the shelter population who have long-term care needs before they have permanent housing?
You want me to take that first shot at that?
Yes.
Sure. So I think the issue is that I think the first and foremost question is that for the shelters, the shelter system, I think in New York City now is, I think 50,000 individuals on any given day. And obviously it's a population with significant needs. And the question is just how best to do that. And I think that home and community-based long-term care services could play a role. But I think it's got to be done in close coordination with the other resources that are brought to the shelters, particularly those that are organized by local government. In the case of New York City, it's the city of New York. And so I think it's an interesting additional tool that could be deployed to address the needs. But I think it's got to be deployed in a way that is highly, highly coordinated in order for it to be a real value-added service.
Thank you. Thank you. And I also want to mention Jason Faith Wiggins wanted to thank you for speaking about maternal health as a racial justice issue. And I have another question.
Cheryl.
So one thing that we want to do, yeah.
Sorry, I was going to ask, can I just comment quickly on the shelter piece as an example, if I'm not too disruptive? I know sometimes data and information, cannot be the most exciting topic for everyone. But I want to just submit this thought for you. Consider everything that Jason just said and think about if you are the state official now and you see in the data that you have 100 people that have the same address, and you're doing asset verification, eligibility, whatever the effort may be, getting them supportive services. If you see someone that has the same address as 100 other people, what is that going to trigger for you? Right? Might be a few things, but the fact that you're looking at the data and you're being predictive and looking at those risk factors for the populations you're serving, that's again why the data is so important. There may be 100 people living at that same shelter and getting services, and you can identify quickly perhaps what you do to better serve those individuals. So I just wanted to share that quickly, Cheryl, maybe just to get minds thinking about, why those pieces are so important and how you take the data to be predictive and more proactive, frankly, with what we have and what we know already. So thanks. Sorry to interrupt you.
It wasn't an interruption at all. I want to thank you for that.
If I can, I just want to build on this too, because I've had this thought in my mind at a couple points in the conversation when Kelly was talking about the importance of interoperability earlier, when we were discussing housing, and I was thinking about how you need to expand the collaboration beyond just one government agency like Medicaid. Housing is one where you have distinct agencies with different funding streams, different policies, different ways that they may be able to support people. And I think when you step back, you have to realize that the cure for a fragmented system cannot be a range of fragmented approaches with every plan and hospital system and government agency going down a path alone. This is where I think the benefit of a common infrastructure really comes into play. And if you're also pairing that with effective engagement with communities and alignment around a common purpose, shared goals, like reducing housing instability, like reducing disparities in maternal health, then you can set up a system for investing in targeted interventions that are likely to move the needle on those disparities and over time correct for the lack of historical investment in critical areas that leave us in the place that we're in right now.
Thank you. Thank you. We have another question to add to Yvonne's question here. Will the independent assessor New York State contract include a directive to make sure that folks will be assessed in a shelter?
Yeah, this is a very specific Medicaid policy question that I'm probably not the right person to answer, as I have been the Medicaid director in New York for 4 years. So I don't want anybody to perceive me as taking the official position of the state. But I think the idea is just in general is that home care, for instance, is an entitlement service in New York Medicaid. So in a sense, anyone who is in need, meaning they have a clinical need for home and community-based services, they're entitled to it. And so that gets a little complex in terms of who's responsible for doing the assessment, but ultimately, regardless of whether you're in a shelter or not, you should be able to access the services to which you are entitled under the Medicaid state plan in New York.
Thank you. I do have a question for you, because one thing that we're talking about, particularly if we are looking at things from a social justice lens, obviously we're talking about the integration of grassroots community-based organizations into care coordination. But there's also leadership at the top, right? And I'm just curious about suggestions for ensuring that state leadership in the Medicaid managed care arena is more reflective, or the Medicaid arena in general is more reflective of the populations being served.
Yeah, no, absolutely. I think that it's a real question. I mean, I think we're very lucky in New York right now to have as the Commissioner of Health, Mary Bassett, who, in addition to her current role, was the New York City Commissioner of the Department of Health and Mental Hygiene. So brings a unique experience, and also as a person of color who leads the entire agency. I think that's an important step forward, but I do agree that we need diversity in leadership across state governments. I think Governor Hochul has demonstrated a commitment to this. Particularly, I think she deserves praise for women in leadership roles. I mean, I think we're at an all-time high when it comes to commissioners across the entirety of state government in terms of women who have reached those roles, many of whom also are of color. But I definitely think that when you look at the insurance industry, you will find that it is a white male dominated industry and remains to this day. Not entirely, but definitely we need to find more opportunities for individuals, and I think we should begin to expect more, particularly in areas like Medicaid managed care, to have a more diverse leadership in those organizations.
Eric,
One thing that I would add.
Yeah.
One thing that I would add, just in addition to the important question about leadership and representation and shedding light on that, I think it's also important to examine what you're doing with that, the power that you do have. Who are you empowering to be a part of the solution for creating a better system of health and human services? And I think in New York, sticking with that state, there's a lot of great work that's underway through this new waiver process with the creation of these new health equity regional organizations and social determinants of health networks, which will be organized, I understand, at a regional level. So you will have community leadership that's represented in a meaningful way in the governance and setting of priorities to help steer the system to focus on these longstanding inequities and disparities in the system. So it's not just who, but also what you're doing with that power. And I see some exciting work coming in the next several months in New York.
Thank you. And we're drawing to a close. So Kelly, do you have any final words or comments?
Yeah, two things. First, in regards to what Eric shared, as a public official, I'll tell you, I prayed every day that I got it right with what I was entrusted with and that I did a good job while I was there. And that weight of responsibility, you know, still remains with me now, just as an advisor and leader in other ways across the nation. We are entrusted with information for people when they are oftentimes in their most critical moments, you know, and they may not be able to think clearly and they may not know everything, every resource that's available to them. And gosh, I just want to reinforce how important that is, that we never, ever lose sight of that. Such an important responsibility. So second thing I'll say, too, is that as, again, you're looking at the pandemic, health support ending, other funding ending. If you want to continue to have the conversation, I feel like today went so fast and there's so much more I could have shared with you today. Please reach out to me on LinkedIn so we can continue the conversation and provide some insight as you're looking at families moving, displaced populations, you know, changing with job loss or job changes still. Those are all very real things that may be impacting the data that you're looking at. And last thing just is that whole person care, as we have those conversations, really starts with good whole person data to begin with. So I appreciate the time, Cheryl. Thanks very much just for those couple of words. Appreciate being here.
Thank you. And I want to thank you again, Kelly Hoover Thompson of LexisNexis Risk Solutions, Eric Bean of Unite Us, and Jason Helgerson of Helgerson Solutions Groups. Thank you to City and State New York, City and State Pennsylvania. And again, I'm Cheryl Huggins-Salomon. It's been a pleasure, everyone. Good afternoon.
And thank you again, John Lentz here at City and State, closing things up here. Thank you to Taylor Justice for being our keynote speaker. Thank you to all our moderators and panelists. Thank you to Unite Us. If you'd like more information, please visit uniteus.com or follow them on social media. All attendees will receive an email with follow-up information. I believe we've taped this recording, should you want to view it again or share that. And thank you to all of our attendees for joining us today. This concludes our program.
Thank you.